Good afternoon. It's my great pleasure to welcome our distinguished guests. Thank you very much for accepting the invitation from us. And our guests and speakers today are Johan Woodward from European Association for the Study of Obesity. The next one, Vicky Moni, Executive Director of European Coalition for People Living with Obesity. And the third one, Maurizio Guigi, co-chair of FPA Obesity Platform. So I hope we will have a very fruitful debate, and the subject is very important. We will speak about obesity, which is a healthcare sector problem, but not only. We will try to define obesity as the recognized chronic and relapsing disease and one of the most challenging public health threats of the 21st century. I can only remind you, and I am sure that our panelists will dive deeper into the matters, that it leads to over 200 complications, including diabetes, cardiovascular diseases, and several types of cancer. What is more, when we look at epidemiology, more than half of the population of Europe is overweight. These are data from 2019, and also in Poland, 1 of 3 adults are overweight, and 19% live with obesity. There are also threatening results of study concerning adolescents and children. So the new to be adult population is even in worse situation. Obesity is not only a medical problem or clinical problem. It carries a heavy economic burden on healthcare systems and society. The total cost of adult obesity in European Union is estimated at the level of 70 billion euro. You can find also in information that it's about 3% of GDP, but I think it is underestimated still. At the same time, currently there is lack of obesity in care pathways. So this pathway is not recognized. And as a consequence, the treatment options and management options of obesity are non-existent or undefined in 100%. So we need solutions here beyond the current interventions that only covers lifestyle changes as a source of weight loss. There is also limited access to comprehensive obesity treatment, so we need to address these barriers. And just to conclude and to finish my short introduction, it's not a single player in the system or stakeholder that can address all these barriers in the obesity environment alone. We should treat it holistically, and the need is urgent. But I am sure that we will have more information and more details information during our panel, which is planned for additional 55 minutes. Respecting the rules of every lecture or meeting, let us start with the definition. And if I may ask Johan to define or maybe to quote some definitions of obesity, and also tell us about the prevalence of this disease and its complications. So Johan, the floor is yours.
Thank you very much. My name is Ewan Woodward. I'm the Executive Director of the European Association for the Study of Obesity. Thank you for inviting us to participate in this important webinar and this session in particular. So yes, to respond to your question and request. I would like to start by quoting the current WHO definition of obesity, which says that obesity is a complex, multifactorial disease defined by excessive adiposity that presents a risk to health. And now, more than that, the Joint Research Centre of the European Union's most recent definition of obesity states that obesity is a chronic, relapsing disease, which in turn acts as a gateway to a range of NCDs. So not only is obesity an important disease in its own right, it is also a gateway to many other chronic diseases, many of the NCDs that we've been talking about I'm sure you've been talking about today and will continue to do so. As you mentioned some of them in your introduction, we're talking about cardiovascular diseases, respiratory diseases, liver and kidney diseases, diabetes, of course, several cancers, and of course musculoskeletal diseases as well. And that's just some of the quoted diseases. We're also talking about people who are living with a disease and coping with that as well. And obesity, in terms of prevalence, is something that is not reducing. It's not being treated as an NCD. It's not having the same attention as other diseases. And according to the most recent World Obesity Atlas from 2023, it is predicted that in just 10 years, so in 2035, in the European region, 39% of men will be living with obesity, 35% of women will be living with obesity, and 21% of boys and 14% of girls will be living with obesity. If you include overweight, which is BMI above 25, according to BMI definitions, you're looking at well above 60% in many European countries in adults. So you can see that this is a disease, it's rising in prevalence, and it is affecting most of the people who are living in the European region. So that's just my opening summary for you. I hope that was helpful.
Yes, it was very helpful. Thank you very much. So if the numbers are so huge in terms of prevalence of people suffering, being overweight and obese, it must carry a lot of burden, not only to healthcare systems but also to economy. Can you briefly comment on the burden of diabetes and maybe also costs related to them? I quoted some numbers, but in my opinion they're underestimated, especially if you include all the diseases that we've tried to list, but there are many more. So how what are the results and conclusions from the studies looking at that?
So if I'm looking at the World Obesity Atlas, in 2025, obesity would already be having an impact of 2.9% on GDP in Poland, 3.1% in just 5 years, and then 3.5% in 10 years' time. And that's, as you say, a conservative estimate because it doesn't necessarily take into account all of the complications of obesity, all of the costs related to those complications. So one argument would, of course, be that if you prioritize obesity, really treat obesity, then you're going to reduce the costs of the other complications, you're going to prevent the other complications. And so you would argue that you would put it at the center of an economic health policy. But I would say, 3.5% by 2035 is a reasonable estimate. But I would also agree that it could be much higher depending on which complications you also include in the analysis.
Right. Thank you very much. So I'm a medical doctor myself, and when we have patients and we code their diseases, there are a lot of conditions that are obesity or overweight related. But we are, even as medical professionals, I think we are not aware of the fact that it's a consequence of certain pathway that the patients move along, and that the disease we code, which goes into statistics, and its treatment is caused by the fact that the patient is overweight or obese. Vicky, my next question goes to you. How should we and in what way should we define the patient's pathway in this disease from very early stage of diagnosis, which is very simple to do. Every GP can do it. But maybe even before, because we can say that the beginning of the patient's pathway is before the person becomes overweight, and then step by step up to the phase in which the patient faces complications of diabetes, either in the format of defined diseases or a multi-disease stage that eventually needs to be addressed by the healthcare system and also a social system.
Yeah, thank you so much for the invitation, and thank you for having me here. You know, it's an honor when it's a patient that's an equal partner at the table and our voice is listened to. So I'm very, very grateful for that. Now, when it comes to patient pathways, there's very little. There is no patient pathways in most systems. And that is the biggest challenge that we have as a patient organization that is pushing for early detection and treatment intervention, because effectively there's no education in the system for our healthcare professionals on obesity as a chronic progressive and relapsing disease. And I'm the walking, talking proof of that. In my lifetime, I've lost and gained between 180 and 190 kilos, on and off, on and off, on and off. And at no point was I recognized as a person who had any sort of NCD until another NCD joined the group. And so exactly as you had said there, the treatment for obesity is actually prevention for another condition. Now, I think part of the challenge that we face is that we have all of these myths and misconceptions around obesity and the stigma that exists within the framework and the prevention that we've put in the past. And we see the stigma in the prevention national strategies. It really is just eat less and move more is public health awareness for all. That is what we tell everybody who has an NCD. It's no different to telling somebody who has skin cancer, there's sunscreen and here's a hat. There you go. That's your intervention. And unfortunately, that's what we've been left with as patients. And the challenge we face now is that because the pathway isn't there, the education isn't in the system for our HCPs, us as patient organizations are pushing at every national level for obesity disease recognition to get our patients into the system, to get them into the GP chair, to get them early intervention. But the GP isn't aware of obesity as a disease, which then causes stigma, and the person does not come back for any intervention. And we notice, like from ACTION-IO studies, we've seen that the average person waits 6 to 9 years before they actually go to their GP for any sort of intervention. And most of the times then, it's for something other than obesity, and then their obesity is addressed. And that is a huge part of what is, you know, given us the numbers that you're talking about today. And I love that you brought up actually teens as well, because we've actually done action in teens as well. And do you know what was really interesting and quite heartbreaking when you go into the study? The majority of the teens said that their biggest challenge and barrier when it came to their weight, because they don't talk about obesity, they say weight, was they could not control their hunger. Not one HCP who answered the survey actually flagged that at all, which means that there is a complete disconnect and the societal narrative is existing and it's living on through policies, unfortunately, which need to change.
Yeah, I can echo that from clinical practice. There was a lady, a patient, and at the endocrinology department treated for some conditions. In fact, multiple conditions. She was 21, 180 centimeters long, and almost 200 kilograms. And she was like they called a consultation, psychiatric consultation to her. And I was speaking to her and I asked her a question. Haven't you ever talked with any of doctors on your pathway about your weight? And she said, well, I like to be a big girl because I feel safer. So that means that the perception of this patient is that if I am so big, so heavy, I'm safe. And it indicates complete lack of knowledge about the risks, but it also indicates that the doctors that who she met several times, including her hospital stay, has never discussed the obesity as a source of her problems. So it seems to me that it's a very multi-stakeholders approach that should be applied here. Because otherwise, without education of not only healthcare professionals, but also a society, I'm very, very proud of the fact announced recently in Poland that we will have lessons on health education at schools. So maybe there is a chance for the children in primary school that they would know what to eat, how to behave, that physical activity is so important, etc., 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 and at least understand what are the risks associated with with having weight that is too high. Let's call it like that way. But I would like to ask you about this multi-stakeholders approach. Who should sit at the table?
Everybody. We all have a shared responsibility. This isn't just down to the patient and the doctor in the GP practice. Like for myself, I've had a multidisciplinary team since I was 28 years old. So nearly 2 decades, I've had a multidisciplinary team. And that is for my intervention, my treatment. And that is exactly the example of what we need when it comes to policy. We need every partner at the table because everybody has a responsibility to this. You know, it's really interesting what you said there about that lady, because that's actually quite common in a lot of stories that we would hear on, you know, patient support groups and that. But it also indicates that there is a need for the personalized treatment or intervention, that there is no one obesity. You know, obviously we know, you know, environmental, that obesity can be environmental, socioeconomic affected. It can be genetic, 40 to 70%. If it's genetic 40 to 70%, you're fighting your own biology and you can't do that without intervention treatment. But what I find really interesting is that WHO now, with the acceleration plan, there are 33 countries that are aligned. Spain is the latest to join from Europe. And in the acceleration plan, I was a part of working on the acceleration plan with some of our team. And I was delighted to see that they've moved from the usual prevention of eat less and move more to, okay, we're going to tackle digital marketing and we're actually sugar taxes. There is so much more prevention, but there is also intervention and education for the healthcare system. And that is the management. And when WHO have finally shifted, and now we're seeing these conversations taking place on a national level, and they can cherry pick from the WHO acceleration plan. They have to take the plan. If they're invested, they are invested. So therefore, this is an opportunity, but we need every stakeholder at the table, which is why I'm delighted that I get to work with the likes of Yoon and EASO and the likes of Maurizio, because these are the people and the voices we need. And we need them empowered and strong, because there's going to be a lot of pushback.
Yeah, so not only we need all the stakeholders, but we also need a coordination of their efforts, because I see the role for the managers in healthcare, but it's also for people financing the system. We have a sugar tax introduced 2 or 3 years ago, but and this money, the intention was to put this money on prevention, also against to fight with obesity or being overweight. and these money, they dissolve in the system, so it shouldn't happen. We really have a burning problem and burning challenge here, and we are unable to address them with the money that should be dedicated to this objective. So it seems that we really approach the stage in which we should take action, recognize the problem, and if I may ask Mauricio to comment on this obesity as a disease and what can we do from early diagnosis to intervention. Why this period from first feedback that something is wrong, if it exists at all, to fighting with diabetes so long in Europe?
First of all, let me thank you for the kind invitation on behalf of the FBA obesity platform that I'm representing today. Let me also, starting from one probably different angle, and I will jump immediately to your question. 85% of the healthcare system are absorbed by non-communicable disease. 90% of the death are related to non-communicable disease. Why we are doing so poor a job in managing this? Because we're managing in a very reactive way. Essentially, the healthcare system is waiting for the complication rather than investing proactively in the disease and preventing the complication. So, first of all, I would like to say that once the definition is set, we need to make sure that obesity is treated for what it is. It is a severe, relapsing, chronic disease. And being recognized by the healthcare system means to be included in the chronicity plan, to set an obesity care pathway in order to allow early diagnosis, and 8 years are far too much for a diagnosis, and enable the healthcare system to cope and to manage an early, appropriate, effective intervention of that. The positive news is that understanding of science and the evidence, as well as the intervention, are available. So it's not a lack of understanding or a lack of processes. It's about executing a non-communicable disease approach and framework in an effective way. But that's require moving from perceiving the intervention as a cost to moving to an investment. And I would say an investment on European health, but also, as stated by Yuan, on European wealth. So getting back to your question, I think that having obesity establish a severe relapsing chronic disease and to enable an early diagnosis and early intensification of treatment appropriately, it's very, very key to not only save lives, but also save money, because as you stated very well at the beginning, obesity is correlated to 200 complications. 70% of diabetes-related complication might be saved also to that. And there is also a lot of correlation both to cardiovascular disease as well as to 13 type of cancers. So there is a lot of investing early on is also preventing a lot of suffering, a lot of cost, and also societal burden as well as economic burden. And let me close also with one remark, and I don't want to be polemic with the first introduction, not by you. Obesity is not an opportunity only for pharmaceutical. It's an opportunity for all the society to do a better job. And I would like also to state that every data are showing that the pharmaceutical costs in the European country are almost flat. What are skyrocketing? It's the cost of the complication. Because as we said, probably we need to think in a more critical way if the managing in a reactive way is still appropriate nowadays. We think that probably a more proactive approach is needed for additional benefit that goes beyond the healthcare that are huge.
Do you think that the leadership role here belongs to the ministries of health in the countries, and the rest should support them? Because we know from different projects that if you don't have a real leader, sometimes it doesn't happen. Or you think that it should be rather ministries who takes care of economy, because they see the burden on people who are on sickness leaves or not able to work at all, or parents being on sickness leave because of different kind of problems and complications of their children, etc., etc. Should it be a social sphere, that societal, or maybe Ministry of Sport, maybe Ministry of Education? We see from our own perspective and experience here in Poland, but I think it's an international phenomenon, that if you have this multi-ministerial kind of challenge, it is also the efforts are multiplied. So it's so difficult to coordinate it on a central level. Maybe we should take the actions on the regional level, maybe individual level. How to structure it in the most effective way? What do you think?
I will start, and then I will be, obviously it's very much needed also that Vicky and Ewan can jump in.
Sure, absolutely.
I would say, as stated by Vicky, it's a multi-stakeholder approach and a responsibility. Obviously, country can be different from country to country. We can have some different nuance. But I would say that it's a European responsibility for setting the direction, the sense of urgency, but also the country responsibility. Definitely a joint collaboration among the Ministry of Health and the Ministry of Economy is a key success factor, but it's a joint efforts where each of us can have a piece of the solution. None of us has the full solution. That's for sure.
But I think that also the clear area of responsibility and a very well-defined objectives should be given. Like Ministry of Education should receive should have a goal of educating children at schools or students, or both of them really. So you need a leader to coordinate that. May I come back to you, Vicky? Maybe you know some examples where obesity, fight with obesity is a goal, an objective of the healthcare sector, maybe of the country as such, because I see that the most efficient, we have some programs of this kind also in Poland, like a program in oncology, in rare diseases, medicines policy. The strategic document was a governmental document, not the Ministry of Health related document. So do you have maybe a good practice in which, okay, this country moves in the right direction? Maybe Scandinavian countries where people have, I would say, completely different approach to sport, eating, being active, being outside. That's of course a part of the story, because if you are ill, So if it is an illness, you can spend tens of hours on different kind of exercises, and you will not succeed. So we all know, sitting here, that it's not a solution given by the majority of GPs in the UK. You are obese, eat less and practice. That's not the way it works for a lot of patients. So what do you think? Do you have some examples to share? Oh, you should switch your microphone on. In every panel, there is somebody who forgets to do that. So no worries, we are used to it.
I honestly think some countries have done well with, the infrastructure they put in place, with the environment, and yeah, of course, the Scandic region tends to show that a little. But I think when you compare countries, look what Portugal did in comparison to Ireland. So in 2004, they recognized obesity as a chronic relapsing disease. They have a population of 20 or 10 million or 10.5 million, and they have over 20 weight management clinics across the country now. Across the country of Portugal. Look at Ireland, half the population, no obesity disease recognition. They are only now implementing the clinical practice guidelines, which they took from Canada and adapted. And we have two weight management centres in Ireland. And that just goes to show that the earlier the government get together and they actually accept that obesity is a chronic disease, they speak about it as a chronic disease, and then actually get the policies and the work in place, that it can work, right? And we're seeing childhood reduction in Portugal, which is tremendous. But unfortunately, we're also seeing, I look at the work of Edexo and APCOI. APCOI is a childhood working group in Portugal, and they are doing the work, visiting the schools and teaching about obesity as a disease, teaching about the importance of your food environment, your home environment, your physical activity, less stigma, that, it's not acceptable. It's the volunteers that are still doing that work in Portugal, even though they've done really well. So yes, there is examples, and I'm sure you would have great examples as well from what you've seen in EASO over the decades, I would imagine.
Yeah, that's why I raised my hand, actually, because I would say that a country that we could look at would be the Netherlands, which has a very integrated care pathway plan. And one of the most interesting things about that is that the person is really put at the center of everything. So there's a holistic approach with lots of different ministries involved, lots of different education levels involved, and the patient really is at the center. And this is quite a new development in the Netherlands. It's a health system that isn't necessarily the same as other health systems across the European region, but it's certainly a country that we could look at as an example of a state-of-the-art system for looking after people living with obesity. Because just to come back to the discussion that we were having before looking at the country examples, I would say that we really need to have a whole systems approach when we're thinking about obesity. Yes, we need to have the Ministry of Health involved, and economy and education. We have to have everybody involved. If you remember the Foresight map from the UK, which is nearly 20 years old now, you can really understand the complexity of obesity by looking at that Foresight map. And I would actually say that a government that takes bold action towards obesity has a real opportunity to make incredible change, both in terms of the health of the population, the economy of their country, the opportunity and the quality of life of their population, and the increased education. And there are so many different things that would need to be done in parallel in this whole systems approach. So, access to care is one of them, but also good prevention strategies that are properly integrated, properly funded, and understanding the difference between prevention, public health, and health promotion as well. And I would also say the foundation of this is education. There's virtually no education of health professionals on obesity in Europe. So I would call, as a call to action, I would say, let's integrate obesity properly into undergraduate medical curricula and have it on the exam questions list so that it has to be taught. And I'm not talking about having one or two modules on nutrition equaling obesity education. I'm talking about the pathophysiology of obesity, talking about full understanding of management, prevention, also interaction with patient, etc. So yeah, I would say perhaps a Ministry of Health would lead, but it's a whole systems approach that we really need, and that's where this multi-stakeholder, multifactorial approach is so important.
Yeah, I do agree with you. We even have a couple of years ago a discussion that obesity is not a disease. So the majority of healthcare professionals, they said it's a symptom. Of course, it's a symptom. They say it's a symptom of many diseases, so it cannot be called a disease. Whereas it's a multifactorial, multi-symptomatic disease at the same time. And if we don't recognize it as a disease, nobody really try to find solution for this disease. So I think this is very important what you say. I have a different question now. We can assume, and I think we all understand that addressing the problem of obesity is the starting point of thinking about European population and about their longer and healthier life. To what extent, and maybe I can ask Mauricio, is it a European challenge, European problem, and to what extent it's a country specific, because you can always use the argument that the healthcare is organized separately in each member state. Can we have a common approach? And I'm also asking that question looking at the approaching Polish presidency in the European Union. Is there a role for Poland? We know that one of the Polish priorities would be education as a part of prevention. I perceive obesity as a very good candidate for these kind of discussions, and the leadership role of Poland. Maybe also before Poland, Hungary, and Poland in the months to come, to plan that activities, and maybe to implement to change Europe for better. What do you think?
Let me say yes to the first question. It's a European problem, but it's each country state problem. So as Johan stated, 30% of the European will live with obesity. And if no holistic action plan are taken. But as also stated previously, Poland is facing the same issue than any other country in terms of prevalence and incidence. So what to do? I believe that, as I stated, but also as has been said, to recognize actively, not only as a definition, as obesity as a severe relapsing chronic disease, and to enable early diagnosis of that, as well as an appropriate effective treatment, is the key. Obviously, each member state are managing the healthcare. That's why coordination from Europe to each state can be very, very important to accelerate these as an investment. And investing in obesity, as we said, is an investment in health, but also in wealth. The other comment, what is the role of Poland? Poland is doing some very innovative project. To my knowledge, there is the project also in the bariatric surgery with a specific BMI approach. There is under conversation another very interesting project on pharmacotherapy, the same area in obesity. So there is obviously an opportunity to keep going to really approaching and improving the obesity care as a state and treating obesity as a non-communicable disease within the NCD framework, early diagnosis, early intensification of treatment, but also with the upcoming presidency as a key role for asking and highlighting the sense of urgency to act, each member states, but also the Commission, and specifically the Commission with the NCD Healthier Together initiative to include obesity within these and also making sure that there is a consistent follow-up to generate the appropriate level of attention and urgency to act. As you beautifully stated, a lot of complication, a lot of disease, and there are plenty of evidence also, for example, that reducing weight by 50%, there are 80% of people with diabetes achieve diabetes remission. Bariatric surgery is bringing 40% of cardiovascular reduction risk. So that there are plenty of evidence, as we said. It's not any longer an issue of understanding. Evidence and science are there, as well as also treatment options are there. It's a question of making our healthcare system leveraging at the best the new evidence as well as the new option that we have.
Right. I think that it's also a European platform is a good common ground for sharing knowledge and some ideas and some initiatives. And I'm sure that there are plenty of them. You mentioned one, the pilot project on bariatric surgery that we implemented and realized in Poland. And we have all the proofs in hand that it helps these patients, that they stop suffering from many chronic diseases all of a sudden. It's unbelievable, because if you ask the question, a medical doctor a question, can you cure your patient from hypertension? Can you cure a patient from diabetes type 2? The natural answer of the majority of doctors would be no, you cannot. It's a chronic disease. When you start treatment, you just change the treatment. You take first tablets, then insulin, blah blah blah. And here I have even spoken with patients who had, but my knee pain disappeared. My hypertension is not a problem anymore, and I don't take metformin anymore. And in fact, I take 2 pills instead of 15 that I used to take before bariatric surgery. So I completely agree with you that the evidence is there, that we know everything, but we need to take actions. And this is a good example. It's not so optimistic because, now we have finished this pilot phase and we are in transition period into implementing it into the system as a whole, which seems not to be so easy. So, it's successful. We know everything. We saved a lot of lives. We saved a lot of money, alleviated the symptoms, etc. But it's not such a fast implementation at the country level, which is a shame, really. Because we have all the data in hand. But I would like to ask you also about the interventions. So the examples of activities that worked well, maybe also on selected markets, maybe even outside Europe. I remember I was attending a lecture during the Congress of European, it was American Diabetes Association, and they were sharing the idea of people transporting food, healthy food, so vegetables and fruits, mainly vegetables, to certain districts in which they could buy only in these big stores. So the highly processed food, that was the only option for them if they didn't use cars, because there were poor districts. And the idea of Americans, I think it was New York or other city, it was an offer to illegal immigrants. They made them stay legal if they distributed these vegetables directly to consumers at the reasonable prices. And there was a whole action to do that. So it's one of the interventions in public health domain, but I'm sure there are many others that worked very, very well. Maybe you know some of them, Jan or Vicky or Mauricio, and they are worth sharing, because some of them are, as this one, it was like not requiring a lot of funding. It's just a brilliant idea to be introduced. Who would like to take the lead? Jan, yeah.
I'll say a few words on that. I think there are some interventions at that level that do work, but they're probably implemented at a very local, community-based level. And one of the things that is a challenge for us is that we are not monitoring any of that. So we don't really have enough data to say what does work, what doesn't work. And some of these interventions have not been properly funded and they've not been implemented. But I would say that we need to think about a whole range of interventions that need to be implemented across society, because as Vicky mentioned in her introduction, the biology of obesity is extremely powerful. So people who are living with obesity are fighting against a very powerful internal biology that is wanting to reset the levels of adipose tissue. And the hormonal system is so powerful that it's very difficult to let's say, win that battle. And so a whole range of interventions across the lifespan are required, because this is a chronic relapsing disease that can't be fixed with one particular intervention for one particular period of time. If you mentioned hypertension, if I stop taking my hypertension medication, my blood pressure is going to go back up. So obesity is no different from any other chronic disease in that sense. Please, Mao has a hand.
No, I will leave Vicky, and then I will make a comment.
No, Maurizio, actually, I prefer if you made a comment. I know we're running short of time, but I'll make a comment at the end.
Very quick answer is that while primary prevention is very, very important for all, my provocative question is, what do we do with the people in need now, the million of people in need now? So we need to have a good balance between primary prevention and making sure that we fight the obesogenic environment, but also a good answer that now is completely lacking for the people in need now. That's the tension that we need to address. And so definitely very good example can be indicated, highlight on the primary prevention. I would hope that very soon we will have a very successful, a great example also in good, effective secondary management of this very severe disease.
Thank you, Vicky.
Yeah, I know we've only a few minutes left, so I'll come in and actually start off the closing remarks, if that's okay, and then we can go around the table. I think that might work. But just to make this a little bit more personal and real, in 1 minute, I'm going to tell you, my grandmother passed away 2 years ago. She had obesity all of her life. Now, when she had obesity, she never had one conversation about it. She went on to have sleep apnea, diabetes type 2, cervical cancer, cardiovascular disease, lymphedema, lipidemia. She literally went through all of the complications of obesity. She was on 22 medications a day, which clearly cost the state an absolute horrendous amount of money, with hospital visits, with mobility issues and everything else that she had. Now, if her obesity had been addressed at an earlier stage, and she had a pathway, she was in the system, she was getting the interventions she needed at the right times, then she may not have progressed to all of those other NCDs. And that's what this is actually about here, because we all know somebody with overweight and obesity. So if you're watching this, I would actually ask you to think of those people in your life, because this is personal to all of us. And this changes lives. When I had my treatment for obesity, I had bariatric surgery and I thought, I'm fixed. I've lost all my weight. Then I had weight regain and I felt ashamed and I failed. This is my fault. I failed without realizing that the treatment had actually failed me. And now I got more treatment and more intervention and I'm in the system. So that's my kind of closing remark, just to make it more personal. And I will pass back to you and Maurizio.
Thank you very much. My understanding from what you said is that we need a holistic approach. It shouldn't be fragmented, because in a fragmented approach we are unable to assess the outcome. So from this respect, and it is not systemic, so it does not address all the problems at every phase of developing obesity and also complications. And I clearly support that. We are running out of time. We have a couple of minutes left. So if I may ask you for final remarks and final conclusions, and maybe if we can list the most important things in addressing the pandemic of obesity in Europe, what would they be? And maybe in a reverse order, we would start with Vicky to list them and to support your choice. And then we would move to Ian and Mauricio at the end.
Thank you very much. So I think for me, the three most important points is that people are actually saying the words obesity is a chronic, relapsing, progressive disease and not a lifestyle disease. That's number one for me. Two, we have to stop having this reactive approach years and years later when people are actually at other NCD stages. And I think as well, the last for me is probably one of the biggest barriers that we have is the stigma that exists. And it exists everywhere, from the healthcare setting to our policies to society, and that needs to change. Until that shifts and people start to accept it, obesity as a disease, we're not going to see movement. Thank you.
Thank you very much.
Thanks. I'll go next, as you asked. As we say, the WHO and the Joint Research Centre of the EU both clearly stated obesity is a disease. There is no debate. So if 30 to 40% of your population are living with a disease, why are you not really prioritizing it? Why have you not got really systematic whole systems, pathways and approaches to thinking about that disease? And I would just say that if I was asking for three things, really invest in education, really invest in early diagnosis and treatment pathways, and think about obesity as an investment for the health, well-being and economy of your country.
Thank you very much for highlighting this investment part of it. We have already discussed that, but it's very important. And the closing remarks belong to Mauricio. So 3 points.
I have to say that Vicky and Ewan make my remark redundant. I think that investing in obesity is investing in health and wealth, I would say. The other element is that we need to call for action in early diagnosis, early intervention. And the last, it's any one of us, it's everybody's responsibility to really drive the proper level of attention and action, not only words. And Poland can play a key role as a member state with some nice, interesting, innovative approach, as you mentioned, but also with the coming Polish presidency at European level.
Thank you very much. The common denominator of these conclusions would be we deserve a change and a big change in our approach to the recognition, diagnosis and treatment of diabetes in Europe. So I think that could be a takeaway point of our discussion. And I would like to thank you very much once again for accepting our invitation. I think it was a fruitful and interesting and lively debate. I would like to thank all of you and every of you for that. And our guests were Johan Woodward from European Association for the Study of Obesity, Vicky Mooney, an executive director of European Coalition for People Living with Obesity, and Maurizio Guidi, a co-chair of FPA Obesity Platform. Thank you very much for your participation and looking forward to supporting our ideas during many events in Europe in the future. There is plenty of work to do ahead of us. Thank you very much.
Thank you for having us.